So my name is Matthew Remedios. I'm a gastroenterologist in Brisbane, Australia, working at the Wesley Hospital here in Brisbane and also the Royal Brisbane and Women's Hospital. We're going to discuss the role I see of Puristat, which is a novel anti-bleeding agent, in the duodenum specifically, where over the last 12 months we're becoming increasingly experienced in its application and starting to see where we see potentially its future utility. As we know, it has got some data to support it in the stomach, and which made us think about its role in other high-risk areas for bleeding. There's two things particularly that make interventional endoscopists nervous, and that is bleeding after duodenal interventions, particularly duodenal EMR of large polyps in the duodenum, and also ampulectomy. They're two high-risk procedures for immediate but also delayed bleeding, particularly even up to 10 days. This is also complicated by a lot of the fact that these patients are older and a lot of them are on novel anticoagulants and antiplatelet therapy that all needs to be restarted, often in an earlier time frame than we think is ideal. We know that current hemostasis modalities have issues. Some of the hemostasis modalities we can put on topically can actually obscure your view. And we also know endoscopic clipping in large defects in the duodenum after resection also is not without risk, and we do get worried about perforation in those areas. So if we can have an agent that we can apply topically when there's bleeding, I think it potentially has some utility, and that's where Puristat may have a role. It also doesn't require blood for activation, so it has some benefit in that it's pH dependent. So I think it does fit in nicely where we're not going to disrupt our defect, but also can help manage bleeding. When we do large field duodenal polypectomies and we do ampulectomies, we do know that there is oozing afterwards and small volume bleeding. And if we can put on the Puristat matrix to potentially reduce that risk out to 10 days, that may be useful. So for the last 12 months, we've been using it for all our duodenal resections and all our ampulectomies. I have probably shifted to do most of my duodenal resections cold, which also reduces bleeding risk. And now by actually adding in Puristat as well, we potentially can also reduce that delayed bleed risk that can be quite significant. So if I see bleeding at the time of duodenal resection or ampulectomy, we place Puristat. We've got an easy application, we don't find it technically difficult. I do actually quite like the fact it's a see-through gel, because actually you're able to see the defect and make sure you don't obscure your views, which can be a problem with other hemostatic modalities. And I quite like being able to see if there are vigorously bleeding areas or other things that concern me about the lesion. And also when we're assessing margins, we don't want to obscure them to make sure we haven't missed any areas that need to be resected. The other issue, especially in Australia, is a lot of our patients do travel some distance, maybe 1,000 kilometres plus to see us. So knowing that you have secured hemostasis in these settings is also potentially beneficial. A lot of these patients also get anticoagulation restarted, often within 3 days. And I think if we know that we have some agent that potentially could reduce that bleeding risk in that situation, I think that's also quite helpful. In terms of limitations, I think it is such an easy product to apply. You do not want everyone to think it is a one-size-fits-all modality. And if people have brisk bleeding that's arterial at the time of procedure, I personally think mechanical hemostasis is best. But for the active oozing, it is particularly very beneficial, and you can see at the time that it actually secures hemostasis reasonably quickly, often within 15 seconds. In terms of technical aspects of it, I do think one has to be cautious about suctioning it off or washing it off too vigorously. So certainly we tend to apply it and watch for a period, and then we'll come out and then observe the patient. I think obviously with my experience, it's my anecdotal experience over the last 12 months, but we do know that duodenal polypectomies and ampulectomies have a high risk of rebleed up to 20%. We've done a number of cases now. I've used it in about 20 cases, particularly in the duodenal resections and ampulectomies. Majority have been duodenal resections and 5 have been ampulectomies. And anecdotally, we did not have any delayed bleeding complication. Part of that is that we did cold resection for a number of them, but on top of that, I think we also had the Puristat as another layer of security, which I think was beneficial. My experience has been that it appears to have reduced any significant bleeding complications. And obviously now, I think the next step is to take this to further trials to see about its actual utility in the duodenum. And I think that is obviously the next place to take this, is in the post-amplectomy and duodenal resection experience.